Welcome everybody. It's 4 p.m. Italian time, so it's time for Food for Veins and Veins for Food. As always, we welcome 30 seconds in order to allow all the attendees to join the platform. So 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. And welcome everybody again to Food for Veins and Veins for Food, a not-for-profit humanitarian and educational initiative that is always starting with the art of Monica Glovinsky, dedicated to the art of all the health professionals who have been so nicely involved in this tough time of COVID difficulties. And indeed, the project is dedicated, as per the request of the Lancet journal call, to the humanitarian support in the economic crisis following the lockdown. Nothing would have been possible without the truly stellar faculty that joined the project from all around the world, who we deeply thank, together with all the friends and colleagues from all around the world that along the way joined this group effort. I'd like to take this chance to deeply thank the two stellar keynote speakers of last Sunday, also for having used their extra time during this week for replying to all the questions in all the languages that we received during last Sunday webinar. So I take this chance to remind you that all the questions can be answered during the week, and you can make all your questions in your language in the question and answer box. We will take the ones with the most likes, so also push the like button if you like the question you see, and we will get the ones that we have time to answer to live, and the other ones will be answered in written form during the week. This week we focus on deep venous, and also, as always, we give international CME credits. We will enjoy two truly stellar keynote speakers. We will introduce them properly, and we have a big news for today, because for the first time, we will also enjoy simultaneous translation in Chinese. So some rapid instructions: if you don't want to listen to the Chinese version, simply do nothing, don't push anything, no button. But if you want to enjoy the Chinese translation, then you click on the dedicated button for the translation, you choose the Chinese language, and once you have done that, you mute the original audio. I take this chance to deeply thank Professor Kasparis, Professor Luri, Professor Narayan, and Professor Urbanek, who have been previously involved in the recording of extra educational material that is truly top quality material you can find inside the BWIN Foundation webpage. I take this chance to thank once again Professor Kasparis, Professor Narayan, and also Professor Jin Song Wang for serving today as honorary chairs, meaning that they will wrap up the take-home messages we should all take home after this webinar, but not before having enjoyed the truly important colleagues' comments coming from all around the world. We will introduce one by one all of them later on. Again, nothing would have been possible without this wonderful group of friends and colleagues, but also individual donors and what we define as the magnificent 7 companies who supported by means of unrestricted grants this initiative. So thank you, Amno, Balton, Bayer, Medi, Servier, Sigvaris, Tactile. I deeply thank you all, and I hope that all of you will be with us at the first chance for a food moment, this time not dedicated to humanitarian support, but to social sharing. That today would have been beautiful to have dedicated with a birthday cake to 2 dear friends, Vicky Smith from England and Ahmed Gawish from Egypt, who are celebrating their birthday. As always, at this point, I pass the mic and the baton to the ones I consider truly wonderful colleagues, but first of all, the family I chose. So, Oscar and Willie, the mic is to you.
Happy to be one more Sunday together among friends and experts from all around the world. I would especially like to thank and congratulate Dr. Gianesini, who yesterday made an outstanding presentation during the webinar we organized for Latin American every Saturday, showing he is a real leader to us. Remember, you can make a question in Spanish in the question and answer box and also lives. Recordarles que pueden hacer sus preguntas en español a todos los de habla hispana y pueden presentarlas en vivo en este momento en el canal o a través de la casilla de correo. Serán respondidas a la brevedad. Muchas gracias.
Thank you so much, Oscar. Now, Willie, that we deeply thank also because it's 7 a.m. for him, so it's truly a commitment.
Morning, good afternoon, good evening, everyone. Thank you for joining us again. This is our 5th time. 女士们、先生们、各位同道们，大家早安。今天是我们第5次的全球网会。如果你对我们的会有任何意见，或者是有任何问题，请在我们的 Q&A 箱里问您的问题，我们会尽快的给您答复。谢谢大家。
And I deeply thank Willie once again also for the help in organizing the Chinese simultaneous translation. At this point, we get started, as always, with a guest of honor. As you know, in every webinar, we always introduce some specialties or disciplines nearby the venous ward, even if eventually not strictly inside the venous ward. And it's my deep honor to have with us also live, so you will have the chance to interact with him, Professor Alberto Caggiati from the University La Sapienza in Rome. We all know him from all around the world because he has been a little bit the professor of anatomy for all of us in the venous ward. And here is his message.
Dear friends, it's a great pleasure for me to be the guest of honor of this webinar participated by more than 2,000 attendees, focusing on deep veins procedures. Dr. Human and Dr. Garcia will expose us their important experiences concerning the diagnosis and treatment of acute and chronic DVT, respectively. However, just a preliminary personal recommendation, deep veins must be evaluated not only in the case of or suspect of DVT. Their anatomy and flow must be investigated in all venous patients because they are the pumping devices of the infrainguinal and pelvic venous systems. Actually, they are involved in all types of venous dysfunction, not only DVT. This is why they are the main target of any rehabilitative protocol for patients afflicted with CVOD. To conclude, a special thank to Sergio Gianisini for his really extraordinary effort in this initiative. Thank you.
And I deeply thank Professor Caggiati, and I want to stress out that it's always a teamwork. So it's my thank to Professor Chi and Professor Bottini, Khaled, and all the wonderful team that there is behind this group effort. In this group effort, we always enjoyed coupling the big keynote speakers with big artistic figures. And this time we decided, since we are talking about kind of innovative things in deep venous ward, to couple the keynote speakers with the ones who have discovered the ward a little bit and sailing around. These are huge keynote speakers who usually needs absolutely no introduction. Also in the case, of course, of Professor Homan Ayelai from Haken University. He is the head of the European Venous Center. He is also the head of the German Society of Vascular Surgery Venous Committee. And is also the director of the European Venous Course. But first of all, he is also a true, kind, and trustful friend for me. And I deeply thank him for his involvement, and I welcome his talk about chronic deep venous obstruction classification. And I ask Jalai to share the screen and let us enjoy his keynote talk. Can you hear us, Homan? Homan?
Oh, yes, dear
Okay.
Sergio, I can hear you. The connection was a little bit bad. Yes, can you hear me?
Yes, please share your screen and start your presentation.
Okay, I'm going to share my screen.
Okay.
So
Perfect.
hope you are able to see my
Yes.
presentation.
Perfect. Just go in slideshow and we are ready to listen to you.
Okay. Yeah, I go without video.
Yes.
If it's okay for you.
Sure. We are all ready.
So do you hear me?
Yes. Just ready to enjoy your talk. Okay.
Sergio, do you hear me?
Yes, we can hear you.
Thank you very much for the kind introduction and the invitation. I'm honored to be here and to be able to talk about the chronic deep venous obstruction with such a nice and big speakers. So my topic is the classification of the chronic venous obstruction. This is my disclosure. So here you can see I am not going and changing my topic from venous to aortic, but I just want to give you an introduction into this classification. Would you agree that I am saying it doesn't make any sense to compare these both pathologies at the left side of the screen, as you can see here, and the right side in regarding the results after surgical treatment? So, Sergio, is somebody else sharing my slides? Because they are running by themselves.
No, very probably you are using the pre-recorded timing. So if it was pre-recorded, you are having the timing of your previous talk.
It is too fast, but I am sharing my own. Shall I share it again?
As you prefer. We can also override you and have Khaled sharing the screen for you.
No, I would share my own, but I would have the control over it.
Yes, you have the control of that. I think you just are using the ones you maybe rehearsed with the timing, and maybe there are the same timings over there.
Okay, now again.
We have different options. If it's not working, we can share the screen of Khaled, who has your slides.
No, I would like to go with my screen.
Sure, please. So there is no problem. And if not, the plan C will be
again
playing the videos.
Then I go back because it was running by itself.
Technology is beautiful when it's working.
Now it's better. Now I have control over it. So this is the introduction, ladies and gentlemen. You see a thoracoabdominal aortic aneurysm at the left side and a AAA at the right side. So, but I am not changing the topic from deep vein to aortic pathologies. But I would say it doesn't make any sense that we just compare the results of surgery, of repair of this pathology at the left side with a AAA at the right side. Even both are from the same anatomical pattern. Both are aortic aneurysms, but there are words between them. So here I am showing now you 3 or 4 examples of chronic venous obstruction. At the left side and at the right side, there are 2 really big differences. Just have a look. These are the venous maps. This is the venous map of this pathology, and this is the venous map of the right-sided pathology. So we cannot compare oranges with apples. So this is a review from Olivier Hartung showing you results of few studies about chronic post-thrombotic occlusive lesions, no nivels, and just have a look on primary patency. There are differences between 30% and 84%. And even if we consider the secondary patency, there are big differences between them. So I go to the next slide. In this slide, I'm showing you a recent published review from Williams. So it was published 2020, and just have a look. These are results of trials with dedicated venous stents and all about PTS. Now have a look of the Stevens results, 59% regarding PTS patients, and Michael Lichtenberg's 87%. But we all know how experienced Steven is and how experienced Michael is, and both use Vichy stents. So believe me, the reason is not a technical aspect or the stent. The reason is because Stephen included more or severe pathologies. The extension of the pathology was probably more than the patients included in Michael Lichtenberg's study. So the most important thing is the inflow and the extension of the pathology below the ligament. So my slides are running by themselves, so I try to be on time. This classification should be based on anatomical extension and the importance of the inflow. It should be easy and practical to use, ladies and gentlemen. The involvement of IVC has really a low effect on decision-making. So we exclude this from our pathology, and a cross-sectional lumen reduction of 50 and more % should be considered as clinically significant. This is the classification. First, you see the group 1, it is just a compression. It could be a Turner compression or somewhere else. The inflow is perfect. We need one stent, endovascularly mannered 30 minutes, 40 minutes procedure. Second group, we have already a post-thrombotic group, but the pathology is not extending below the ligament. Both inflow veins are perfect. Even the common femoral vein is perfect. So it can be easily performed in endovascular manner with 1 or 2 stents with a good patency rate. The second group is a post-thrombotic group, but as you can see, the post-thrombotic changes are coming below the ligament, but deep femoral vein and femoral vein both are patent and the inflow is good. It's technically a little bit more difficult than group 2, but still we can manage it in an endovascular manner without endophlebectomy or stenting into the deep femoral vein or femoral vein. Now we come to the so-called extensive chronic venous obstruction. The group 4A are patients with extension of the pathology below the ostium or above the ostium of deep femoral vein going into the femoral vein. That means one inflow vein, the deep femoral vein, is patent. So these patients have a patency rate after treatment, we know it, of about 60%, 50%, even somehow less than that. So they can be mannered in endovascular manner plus endophlebectomy or endovascular of iliac tract and stenting into the deep femoral vein. The group 4B is vice versa. That means the iliac tract is involved, the deep femoral vein is involved and occluded. The main inflow vein is the femoral vein. So in this group, we need also endophlebectomy after recanalization of iliac tract and then or stenting into the femoral vein. And the group 5, excuse me, my slides are running by themselves. Group 5 is an occlusion of both inflow veins. They should be considered as contraindication, or we should use the PTS access trial. Mark Garcia is here in a study setup. So here are the preliminary data. Excuse me, they are running by themselves. So these are the preliminary data of 380 patients of the validation of this classification. 14 centers are participating, but these are just 1/3 of the patients. Just have a look on patency rate, excuse me. Now, these are the patency rates. I hope you can see them. So if we go from left to the right, we have 100% in the compression group and 60% in the 4A and 4B group. We excluded the group 5 because the patency rates are somehow about 30%, 35%. So the inflow does matter and is the most important issue. So these are the participating centers from all over the world, from US, Iran, Germany, UK. And the clinical impact of this classification, ladies and gentlemen, should be the aid of scientific reporting, comparison of results between studies, comparison of stent outcome, to ease the decision-making for indication and contraindication, and to support our therapeutic decisions, hybrid, conservative, and of course to predict outcome easier. So on behalf of all participant centers, thank you very much. and I hope it was somehow understandable despite running a little bit wrong, but I hope we can discuss all patterns, all issues of this classification. Thank you very much.
Thank you so much, Eli. Please allow my screen sharing, Khaled, so that we can move forward. And now, as always, we have the World Scientific Round, where we have top continental experts who are serving with their expertise in delivering fundamental questions to the keynote speaker. And it's my true honor and pleasure to introduce a wonderful professional, but also a wonderful friend, Professor Rashad Bishar, founder with many other Egyptian friends like Wassil Atta of the Egypt-Africa Venous Lymphatic Association. So, Rashad, the mic is on you.
Thank you, Sergio, for having me participate in this webinar. It's really an excellent webinar, very well organized, plenty of very good scientific material. And of course, the presentation of Huma and Jalai is excellent, much as expected. Very good morphological classification of chronic iliac vein occlusion. My question is, do you think that adding physiologic testing, such as plethysmography, or hemodynamic testing, such as flow volume measurements, would add value to the morphologic classification to help us decide which patients would benefit or would not benefit from stenting, in particular, those falling in group one, in class 1, 2, and 3 of your classification? Thank you.
Hello, Professor Bishar. Nice to meet you here. And thank you for this question. Yes, indeed, this is very important to take in consideration the hemodynamic pattern, because we are talking about results after duplex, after CTV, after MRV. So that means the anatomical extension of the post-thrombotic trabeculation down below the ligament and going into the inflow veins. But we are now working on it for the last 4, 5, 6 years, working on pattern of inflow. We are measuring every time in a supine position with the same duplex machine in the same room at the same level, the inflow from the vein that is a little bit above the ostium of deep femoral vein in supine and in upright position. But believe me, till now, after having treated many patients, over 1,000 patients, we have not a real threshold. We think the threshold is 200 milliliter per minute, but all of my colleagues here will ask me now, yes, but with which machine, who, in which room, in which position? So to have really an evidence for the right volume of the inflow, that will be very difficult. And of course, the classification would be much more difficult to use. So therefore, after talking with all participating centers, we'll reduce it on the most important pattern, which till now is the anatomical expansion and involvement of the inflow veins. And of course, we take in consideration the area, the involvement, not only in CTV or MRV, we just look really detailed into the area reduction and hope the 50% reduction or more considered as hemodynamically relevant is correct.
Thank you so much, Oman. And now it's my pleasure to fly all the way to Buenos Aires to ask Professor Bottini to fly to Europe and introduce the continental expert from Europe. Oscar?
Thank you, Sergio. Thank you, Dr. Human, Dr. Bishara. Now let me introduce Professor Dogansi Swat from Ankara University. Professor?
Thank you, everyone. And also thank you for Sergio for including me to this very wonderful project. And now I want to ask a question to my also dearest friend, Human Jalai, about his new classification. So he also mentioned during his presentation that we have very different results from very different articles. So we know that we also have recent review articles and results of several studies from maybe every dedicated venous stents. So according to the base of this classification, I think we should reassess the results of these maybe review articles and dedicated stance results. So, and as the base of according to the new classification, comment on this issue, because we shouldn't compare, as you said, apple to the orange, maybe nivels to the when post-thrombotic syndrome patients, because you shows us now we have 5 PTS classification. If we say just PTS, I think it's not enough.
Thank you, Suat, for your comment. Exactly. Just again, Steve is here, but that are really the best numbers. Steve is much more experienced than me, and we know how many years he is working with recanalization of chronic venous obstruction. So the technical aspect can be ruled out. Also, Michael Lichtenberg. So one had a primary patency rate of 59% or 58% and other 87%. So believe me, the only reason can be the differences of inflow of patients they included. So just excluding the nivel, of course we cannot tell PTS exactly as on the introduction slide. We cannot compare the results after surgery of thoracoabdominal aortic aneurysm type 2 with a AAA. Also, both are aortic pathologies. So it is a good idea to run this classification or to run the studies of stents, Abre, Vernacular, Vici, Silver Vena with this classification, and to see as another additional validation what the patients are doing.
Thank you so much, Oman. Now we fly all the way to North America for a very, very expert continental representative, and it's my pleasure to pass the mic to Professor Chi to introduce him. I will take this chance to remind all of you that we are under simultaneous translation in Chinese, so if we can try to speak as slow as possible. Thank you.
Thank you. Now we have Dr. Paul Gagne from Connecticut, who needs really no introduction. He's the leading figure in deep venous intervention.
Thank you. And I want to congratulate the Food for Veins organizers for an excellent program and Dr. Jalai for an excellent presentation. I have the following question. I applaud this anatomic classification and congratulate you on the preliminary data that you shared. I'm concerned, though, that the results from your current centers of excellence may not be generalized without adding a technical success score to your classification system that is assumed in your current study. Though you can stratify patients pre-intervention by the extent of deep vein occlusive disease, you also need to know the technical success of the reconstruction to understand the differences in patency. Specifically, isn't it necessary to score the repair at the end of the procedure, perhaps with an IVUS pullback, to assess the inflow, reconstructed vein segments, and outflow for lumen adequacy and for residual stenosis? Thank you for your comments.
Thank you very much, Paul, for this comment. Yes, IVUS, just to show the importance of IVUS. Of course, in the pre-op session, we have to evaluate the patients without IVUS. So I am not going to puncture patients in group 3 or 4 in the popliteal vein and then look with the IVUS. So we use our duplex, CTV or MRV and combine it for a pre-op evaluation. And we have a plan. So we have a brilliant vascular technician who gives us really the best venous map. But I know Jerry O'Sullivan is using CTV. But of course, in the OR, after opening or traversing the pathology, after being able to pass over the catheter of IVUS, we use every time IVUS in these patients. And also with IVUS, we correct our pre-op plan. Of course, this is not mandatory in all cases, but in all extensive cases. But I cannot put now these findings and combine it with the outflow problems. Of course, we know the techniques of stenting from healthy to healthy. This classification shouldn't come in confrontation with these rules, but this classification should make it easier for us if we talk with patient. If I am talking with patient with a compression, I can tell this patient I have you will have a patency rate of nearly 95 to 100%. But if I have a 4A group patient or group 5 patient, I am not able to tell this patient or show a paper of Neglen and Raju and show and tell, look, we have over 85% patency rate. This would be a lie. So that helps me in this problem, and that helps me 1-2 steps further in comparison of stents with each other. You know, we have wall stents, you use wall stents with best patency rates. I use dedicated venous stents with the same rates, and Stephen is using more arboreal stent with the same rates. So even now we are not able to compare these patients with each other and these stents. So I think this classification helps us 1-2 steps further. Of course, this is not the solution of all problems.
Thank you so much, Auman. And now we have a big flight all the way to Asia, to the University of Mahidol in Bangkok. And it's my deep honor and pleasure to introduce a significant expert in the field, Nutout Sermaseshandawadi. Nutout?
Yes. Yes, thank you, Sajid, to invited me to be here. And I would like to say congratulations to Professor Jalai for excellent presentation. I have a question about the type and duration of the anticoagulation for the patient in each type of your classification. Thank you.
Thank you very much. So till now, the anticoagulation is not divided with all groups. But of course, if we have the group 1, which is a compression site, it shouldn't be only a miterna. It could be much more distally at the external iliac vein. Then we use new oral anticoagulation for 6 months maximum. And then if the inflow is okay, the stent is okay, everything is okay, we stop it. But if we go to the post-thrombotic groups, that means group 2, 3, 4, 5, I think in our regime in group 2 and 3, if everything is okay, if in rigid post-operative flow, in duplex, the inflow is okay, the outflow is okay, if after IVUS during the OR, everything was okay, after 1 year of anticoagulation, we would like to stop it. Of course, we have to take in consideration other pathologies like thrombophilia and other things. But in the extensive group, that means for A, for B, and 5, we would recommend and go for lifelong anticoagulation.
Thank you so much, Oman. And now we have concluded the World Scientific Round, and it's time to give the mic to all the audience. There is a significant number of attendees, and the one that is winning in this moment in terms of likes in the question and answer box, where I remind you, you can put your questions. So please, in the question and answer box, not in the chat box, is Raoul Jindal. And he is writing, "Dear Jalai, great talk, and I think we needed this classification, but I feel symptoms of the patients should be definitely included. As you've seen, sometimes the 6th grade is without any symptoms and grade 1 is associated with a lot of symptoms. Therefore, a non-anatomical classification should not be the plan for comparison, as all the results will be misinterpreted." Would you like to comment, Auman, on this one?
Yes, of course, Jindal, thank you. It is correct. It is correct, and doesn't mean if we have this classification, we should forget our daily work. We should forget compression. We should forget evaluation of patient. Of course not. This classification should bring us 1-2 steps further in order to be able to compare our results with each other, to be able to tell something, just one thing about a dedicated open cell stent and a closed cell stent, a comparison of wall stent with Abre or with Vinovo. So of course we are treating our patients due to their symptoms. I am not looking if the patient is 4A or 4B or 6 or 5, if the patient has no symptoms. I am not treating any patient with total occlusion, but if the patient is asymptomatic.
Thank you, Owen. And then the silver medal goes to the Cleopatra of phlebology. She's always like making so good questions that she's always ranking high. It's Wasila Ta from Egypt. Great talk, Owen. Very useful morphological classification. Patient in 4A with occluded femoral vein. In certain patients, a duplicated femoral vein will take over. Could you still consider 4A or not?
What was the question? Could I consider 4A as what?
She's saying very useful morphological classification.
Yes.
Patients in 4A with occluded femoral vein. In certain patients, a duplicated femoral vein will take over. Could you still consider 4A or not?
So we are going now into detail. Of course, if a patient has duplicated femoral vein and one femoral vein is a good femoral vein, let us say 10 millimeters in diameter or 8 millimeters in diameter, and we see in our way of approach with duplex and MRV that we can consider this as a good vein, and the deep femoral vein is also patent. Yes, of course, we should consider it as a good vein and open, and we have 2 patent veins. But if the duplicated veins are very small and one is occluded, the other one should be considered just as like a collateral, then I would consider it as occluded.
And Mohamed Hassan is asking you, which imaging modality will you use to determine the classification? CT, ultrasound, IVUS? Yeah,
very good question. We use duplex and MRV in pre-op setting. In OR, we use in extensive disease and occlusions every time, additionally IVUS every time. And then we can make our classification. Really, it is not that difficult. But I know, again, that other centers are using duplex and CTV, or they are using CTV and sometimes MRV. So it should be in the hand of experts. You should be familiar with the tool you are using, and then you make your decision and you can classify the patient in these groups.
Very last questions from Latin America, so I will ask support from Oscar if I translate in the wrong way. It's in Spanish, it's Carlos Lopez, so he's asking if there is any register of the frequency of venous obstructions. So I don't know if you know, Homan, if there is any registry about chronic venous obstructions in Latin America, and I extend the question also to Professor Lobato, who is a world leader in this. So is there any registry in Latin America?
I do not know if there is any registry in South America. Last year I was in Brazil and had workshops and was in the Science Congress. There are colleagues who are very familiar with these pathologies and they are doing recanalization. So therefore, I think there should be a registry in this continent.
I will ask Professor Lobato if he can unmute himself, because we have the honor of having truly a key opinion leader in the field. And if you want to make a comment, Armando, on the registry, eventual projects of doing that.
We do not have in Brazil any registry study that actually 2 days ago have this discussion with the Brazilian Vascular Society that you need to do that. You need to do some registry at least. But unfortunately, at that moment, you do not have.
Thank you so much, Armando. It's a perfect time to move now to the next keynote speaker. And if it was Vasco da Gama, the first keynote speaker, the second one must be Cristoforo Colombo, because he is indeed one of the pioneers in this field. It's Mark Garcia, needs no introduction, is the pioneer indeed, is the head of the endovascular consultants in US, a true key opinion leader, and truly a great friend with a great heart, because he has been involved from day one in these not-for-profit initiatives. And I will pass now the mic to him so he can share his slides and talk to us about chronic deep venous thrombosis, diagnostic and therapeutic decision-making. Mark, unmute yourself. Perfect.
Yes, thank you. And let me just get the screen up. Okay.
Perfect. Perfect.
Great. Well, first of all, I want to thank doctors Sergio, Willie, and Oscar for the honor, true honor, and opportunity to speak about chronic deep vein thrombosis. And congratulations to you all on the Veins for Food, Food for Veins, and the amazing global education that you're doing during this pandemic. So here are my disclosures. First thing that I think it's important to understand is DVT and post-thrombotic syndrome and the facts. If you look at the per capita rate of acute DVT, and you look at the overall population, both in the US and globally, with the data that we know from previous studies of up to 50% of DVT patients creating post-thrombotic syndrome despite therapeutic anticoagulation, in addition to the fact the ATTRACT study showed that in both arms, 44% of Fem-pop DVT patients develop post-thrombotic syndrome. When you extrapolate this data, we're talking about more than 60 million people globally suffering from some degree of post-thrombotic sequelae. So part of the decision here is in the decision-making steps is first, who is the ideal chronic DVT patient that we should be looking at treating? Well, first of all, they obviously have to have chronic veno-occlusive disease. And I think the ideal time is probably between 3 and 6 months, maybe 6 months. This is something that needs to be borne out as time goes on. They should have failed conservative therapy, including therapeutic anticoagulation and compression. They have to have persistent signs and symptoms of post-thrombotic syndrome, which by their words, they report quality of life limitations. Most of the people that we're treating would be classified as CEEP 4 to 6, but I would include CEEP 3 patients who have significant and resistant swelling despite treatment with compression, elevation, and activity. Their comorbidities should not preclude them from intervention. They need to understand the risks. And clearly the benefit of treating this patient population should far outweigh the risks of undertaking the treatment itself. But one thing, and I think from the previous talk you heard, we should not exclude Fem-pop occlusions. When you look at femoral vein occlusions, actualization that may occur is not always adequate to decompress the elevated venous pressures below that level. And certainly when we have popliteal disease and occlusions, this can cause severe calf post-thrombotic sequelae because it is the main outflow from the calf. And again, remember, during the ATTRACT trial, we saw 44% of Fem-pop DVT patients develop post-thrombotic sequelae. So when we talk about preparation, the initial evaluation is obviously very key. You want to do a full history and physical. I would include CEEP, Villalta, VCSS scores, and quality of life data. We do this on every patient, and we do it completely through our follow-ups. You want to identify risks for intervention. You want to obtain and review all appropriate imaging, whether it's just venous Doppler studies, or if you suspect something more centrally, you should get CT or MRV. And again, pictures and venous scores are done at each visit. It really helps to document the extremity status. And as they say, a picture can say 1,000 words. Here's an older gentleman who had clearly very severe post-thrombotic sequelae. And a month later, after recanalizing his femoral popliteal system, he was much better, although by using just straight venous scoring, he would still have quite a high score, but he was actually back to the ballroom dancing with his wife, which he hadn't been able to do for 2 years. A significant improvement in just the overall appearance of the leg. So second step, preparation is with imaging. This is probably the most important step. You really need to know the anatomy. What is the extent of the occlusion from the peripheral edge to the central edge? You want no surprises when you start the procedure. So you need to obtain and review the imaging. If you really suspect on exam just infrainguinal only disease, then I think a venous Doppler is fine. However, if you suspect anything in the suprainguinal area, you really should proceed with CT or MR venography, again, to identify the extent of the disease centrally. This also helps us decide on the access site. And this may be the most important thing of this talk. The goal here is to reestablish direct inline flow from the ankle back to the heart. You want to leave no lesion untreated. So we access below the lowest level of the disease. In looking at this, the access site determination, again, remembering the goal is to establish direct inline flow from the ankle back to the heart. So if on Doppler study, you see that the popliteal vein is patent, then a popliteal access is normally what I would do. However, if there is any significant disease or occlusion, then I start at the posterior tibial vein. In all honesty, all patients, I start at the posterior tibial vein just to exclude any webs or synechia that are present in the posterior tibial or popliteal level. But nonetheless, again, it's very important to get direct inline flow. Sometimes you may need an additional access, whether it's from a contralateral side or from the internal jugular vein, to allow for through and through recanalization. Again, access below the lowest level of the disease to get the best results. These are the materials, this is the methods that we use in the Access PTS protocol, which we'll get into a little bit later. There's typically an overnight stay in the hospital. Patients get started on enoxaparin. Standard CTO techniques are used to gain access across the occlusion. We then balloon angioplasty to what would be the expected normal size of the vessel that's diseased. And then we put the ultrasound accelerated device in and treat at either 0.5 to 1 milligram overnight within the disease segment. Day 2, they come back with follow-up imaging and angioplasty or stenting if needed. They get discharged later that day on enoxaparin, so it's really an overnight stay. They go home on 1 milligram per kilogram twice daily for a month and then get transitioned over to an oral agent. They are told to wear compression socks and initiate an exercise program, which simply could be walking day 1 after the procedure. And then we follow them up at 1, 3, 6, 12 months and yearly thereafter for 5 years. As far as crossing the occlusions, as I mentioned, it was really standard CTO techniques. I start with a Navicross and a stiff straight glide wire. This works probably more than 90% of the time. And if you need additional techniques such as the Cook Triforce or re-entry devices or sharp recanalization, they are obviously available with the key being to get across the obstruction. You want to exchange and work over a stiff wire. And again, as far as anticoagulation, I typically start enoxaparin prior to the procedure. Many people have talked about starting after they cross the occlusion. Either way, whatever you feel more comfortable doing is fine. I think the added benefit of enoxaparin is, beside from heparin, it's really the only other oral agent, anticoagulant that gives you anti-inflammatory properties, which from our friends in Michigan, we've known that inflammatory responses are tremendous in thrombosis. So we want to keep that to a minimum. So as far as the Access PTS, once we get across, right now, this is the treatment option of choice. The study was published in February in the Journal of American Heart Association. I put this on for you. If you feel like looking at the manuscript, go ahead and you can see all the details from that journal. So it was a multi-center study of 29 sites in patients with symptomatic lower extremity DVT for at least 6 months, confirmed with ultrasound, who had to have at least femoral DVT. They had those who had isolated iliofemoral DVT were excluded because we all felt that obviously they would be stented up front. They had to have failed minimum conservative therapy with therapeutic anticoagulation and compression for at least 3 months and have a Villalta score of at least 8. The primary endpoint was a 4-point reduction in Villalta at 30 days in at least half of the population. We actually saw 65% of the population meet this endpoint. And at a year, it actually went up to 77% that had a 4-point reduction in the Villalta scoring. These are the graphs of the results in the change of Villalta, VCSS, as well as the improvement in the SF36, PCS, and veins quality of life. All of them were statistically significant with p-values less than 0.0001. Interestingly, as we heard from the last talk, I think this only shows exactly what we need when we treat these patients, which is that direct inline flow. When you look at the Doppler patency of our population, whether you looked at common femoral, proximal femoral, distal femoral, or popliteal, the results were outstanding in this population, all greater than 90% at 365 days. So a year out, once you reestablish flow, and by one of the measurements we used in flow was an establishment of the washout phase. This was looked at by Dr. Oriel using both Marder and Oriel scores, and we showed the data was difficult to evaluate, but it did show a tendency that there was statistically significant improvement in flow following the treatment in these occluded segments. So obviously flow is key here to maintain patency. Of course, a couple case examples. This was a 2-year-old Fem-pop chronic venous occlusive disease in a young woman who was a marathon runner and an extreme bicyclist who had a head injury from a bicycle accident. And in her hospitalization, she developed extensive DVT. 2 years out, she was still suffering from severe post-thrombotic sequelae and was unable really to do any running whatsoever, had difficulty standing for too long of a period of time. And you can see on the initial venogram disease in the popliteal and femoral veins. This was after overnight. And again, you have to look at the washout phase. The vein is ugly. It doesn't look good, but there is flow. And that is really what's key. You can see there's significant reduction in the collateralization. And this woman did absolutely fantastic. And 6 months later, she started running a marathon again. Here was her 2-year follow-up Doppler showing the common femoral, and popliteal veins to be remaining patent. One of the most interesting things we found in the last 10 to 15 years of doing these patients is that somewhere between 6 and 12 months, the venous Doppler that initially showed a very thickened, non-coapting vein, but it had color flow, starts to coapt. The vein starts to what I'll call remodel and actually looks more normal. I'm not saying the valves are normal, but the veins actually look significantly improved between 6 and 12 months with coaptation being seen. This was a 15-year chronic veno-occlusive disease with severe PTS in a woman who had pelvic chondrosarcoma and 3 years later developed extensive DVT. And over 13 years, she had progressive post-thrombotic sequelae and was wheelchair bound. She had a painful, tense, thickened, leathery leg that was quite devastating. Her Villalta score was a 30. She did not actually have any ulcers, but she had severe disease. And you can see from the pelvic venogram, she has had the hemipelvectomy. Her femoral vein is riding very high. And on the MR, you can see the very edematous, thickened skin and large leg compared to the opposite leg. This was her initial venogram. It was a challenge. She had a very wispy popliteal that we were finally able to get into. And you can see just how small these venous channels are where they occlude in the upper thigh with no outflow except for very tiny cross pelvic collaterals. This was, again, after our overnight treatment. And you can see that we actually reestablish flow in a very irregular and diseased vein, but it is present. And after stenting the more central veno-occlusive disease, we can see flow out of the leg back into the IVC. And you can see again, a key is flow. That is truly what makes the difference. In follow-up at 1.5 years, she remained patent on Doppler ultrasound. She had significant clinical improvement. She was out of the wheelchair, walking with a cane amazingly with that leg until she finally succumbed to her disease. This was her follow-up venous Doppler at that 1.5 years, again, with significant improved flow throughout the patent venous system. And last case is a 5-year-old chronic veno-occlusive disease in a severe post-thrombotic patient who actually had an ulcer, an ankle ulcer. And you can see the disease in the level of the adductor canal. I think it's very important to get close up with a catheter and inject because you can see there's a string sign. That's what we go for. And once we get engaged, we can get across. And after an overnight treatment with the Access PTS protocol, you can see the very brisk flow that was obtained. And he had healing of his ulcer at the 30-day follow-up. On discharge, all patients are sent home on enoxaparin, 1 milligram per kilogram twice daily for 30 days. Once that's completed, we have the ultrasound. We transition them to an oral anticoagulant. And all patients are strictly taught the importance of what I call the rules of ABCs of DVT. And my rules of the ABCs are activity, blood thinner, compression. They start walking or exercising the day after the procedure. Again, on enoxaparin, transition to an oral anticoagulant at 30 days, and then compression. I do not make patients wear 30 to 40. I think it's very difficult. Most patients will complain about it. I want them to wear something. We've accepted 20 to 30, and actually patients are very willing to do this, and the results, again, have been excellent. They are told to wear them from the time they get out of bed to in bed until follow-up at some point in time, usually between 1 and 2 years. We tell them they can try to start going through life without wearing them. So in conclusion from the Access PTS, it's statistically significant study showing that we reached the primary endpoint. And based on Volata, VCSS, SF36, and veins quality of life, they all had statistically significant improvements throughout. And the patency on Doppler studies were phenomenal at greater than 90% when we were able to definitely get flow restoration. So I beg all of us in medicine that when patients are suffering from chronic veno-occlusive disease to stop saying there's nothing that can be done. Endovascular intervention is clearly here. It is safe and effective in recanalizing chronic venous occlusions. And the Access PTS protocol showed that there is statistically significant improvement in post-thrombotic scores and sequelae based on Volata and VCSS, and improvement in quality of life based on SF36 and veins quality of life. So hope is here for those patients who have failed standard of care therapy. Thank you.
And thank you so much, Mark, for the really worthy of Cristoforo Colombo keynote speaker. I will now pass the mic to the second scientific vote round, and it's my deep pleasure and honor to introduce for the second time, because I already had the pleasure of introducing Steve Black as keynote speaker in a previous webinar. We define him as our Sting, like the singer. So I will pass the mic to Sting in this case. Steve, it's up to you. Unmute yourself. You're still muted. You're still,
yeah,
okay.
Sorry,
okay.
Technical difficulties. I was still looking at that picture of me from 10 years ago and wondering what's happened. Mark, thank you so much for, as always, an amazing presentation. And I think you hit on something that for me is crucial. You know, when ATRAC came out, pretty much everybody has stood on a podium and gone, ATRAC's correct, we don't treat femoral vein disease, we should have focused on the iliofemoral, and that's where our attention should be. Your data and your presentations are completely contrary to all of that, and bring us back to looking at the femoral vein and saying, you know, we should be treating that as well. And the reason why people took that view is so many people struggle with the femoral vein. So some of the cases you showed now look to me to be Human's sort of category 5 group of patients that universally do badly. But at Access PTS and the cases I've seen you do, you get really good results in that group of patients. So what do you think we can take away as a group from what you've developed over many years that can help us push the boundaries on those patients?
Yeah, thanks, Steve. It's great to see you. And again, congratulations on all the work that you've done. You know, I think the most important thing that I have found over the last 15, almost 20 years of doing this is that the flow is truly the key. You know, at the end of the day, when we're doing these patients, I think, you know, initially we started doing patients with popliteal access on everybody, whether they had popliteal disease or not. And I think that's a mistake. We need to go to the lowest level. We need to do everything we can to unmask any lesions that are present. And the flow phenomenon on venography is really important. If I can get that flow and a washout phase that's relatively reasonable, those patients do tremendous. When we have unprovoked DVT patients, I think it's also imperative to make sure that despite what venography looks like in the iliofemoral segment, that you look at it with IVUS. It's amazing the percent of unprovoked DVT patients that extended down into the Fem-pop region actually have lesions in the iliac region that were not identified on venography. So again, it's just a matter of taking your time and really trying to understand the anatomy and what may be the causative factor and removing that from the equation. And then lastly, it's just we are very, very aggressive with anticoagulation, compression, and activity. You know, our patients have been excellent in doing this, and the ones that don't are the ones that fail. But if they understand, look, most of these patients have been suffering for a long time. They're willing to do whatever it takes. And so it's not been a hard thing to convince them to follow the rules, and they typically have. So.
Thank you so much, Mark. And now we fly all the way to North America, but also with a touch of South America. And I will pass the mic to Oscar Bottini to introduce the keynote representative, even if I'm a little bit sorry, because I would have liked to introduce him because he's a really dear person to me.
Thank you, Mark. Good to see you again. Now let me introduce Luis Leon, a person who I admire and respect, a real close friend to me, from Arizona University.
Luis?
Muchas gracias, Oscar. Congratulations to Willie and Sergio and Oscar for such an amazing presentation in international reach. Mark, good morning. Enjoy your presentation very much. I have a question. The clinical benefits for patients with chronic deep vein post-thrombotic changes shown by your trial results are clear, undeniable. Now, of course, it's the only hope currently for interventional treatment of this very large and unfortunate group of patients. However, the precise mechanism through which ultrasound-accelerated thrombolysis helps these people is unknown and goes against our very basic knowledge about thrombolysis and its effect on fresh clot that, as we all know, is formed by fibrin versus all chronic clot, which is very rich in collagen. So in a few words, can you please describe to me what in your mind is the precise effect of thrombolysis on these chronic cases? Again, thank you for your presentation and your amazing research.
Thank you, Luis. It's great to see you again, my friend. So, you know, this question always comes up, and I wish I could tell you with 100% assurity I have the answer. What I do, I can tell you what our basis was for initiating this whole study. The TPA was initially placed for the patients who were developing acute thrombosis when we would go into the occluded vein and balloon dilate these segments. There was clearly some acute thrombus. That was what the TPA was for. It had nothing to do with what we knew was collagen. But what we found was that, and what is believed to happen, has been supposedly shown by the company in lab work, is that there is the effect that the ultrasound may get into the collagen fibers and that cross-linking and help to soften that link. And the example that I talk about where I think this effect is real is that we've had numerous cases where day one, we've dilated with balloons up to 30 atmosphere and have been unable to break the waist of the disease that we've seen in the femoral vein, for example. We bring them back the second day after the ultrasound accelerated lysis overnight, and you can inflate a balloon 8 to 10 atmospheres and it pops very easily. So there is clearly something pathophysiologically going on there that I don't think we have the answer yet. That's hopefully research to be done in the future, but I think there's clearly an effect that we're seeing that allows these veins to become more compliant, and which is why I think that over time, we're seeing the changes that we see on venous Doppler.
Thank you, Mark.
Thank you, Mark. And now we fly all the way to Latin America. I would have liked to introduce myself, the father of CISA meeting, a meeting that we should all attend at least once in our professional lifetime, but I will leave this honor to Professor Chi. Willie, can you introduce?
Well, thank you for the honor. Great lecture, Mark. Next, we have somebody who's a world-renowned figure, Professor Armando Lobato, who Sergio had already introduced, who holds one of the biggest meetings in the Latin America, if not the world, CISI. Dr. Lobato.
Unmute yourself, Armando. Unmute yourself.
Thank you very much, Sergio. That's a great pleasure to be part of this amazing meeting, this webinar. And Professor Garcia gave an amazing study and the very good results. My question is about the Villarreal score. In the majority of the cases, the indication for endovascular treatment is in the severe cases of that. In the Villarreal score means 15 up to 48 points. In your study, your inclusion criteria, you show that we started in the 8 points. So it means for the Villarreal score, that's a mild severity, even not moderate, it's a mild severity of the score. So my question, did you have the opportunity to scrutinize your results in two groups? For example, less than 15 points and more or equal for 50 points, if the result is gonna be the same, or you have some difference between 15 or more than 15?
Good morning. Yes, thank you for the question. It's a great question. So the mean Villalta score, when we designed the trial, we just wanted to make sure that we had something that could show a change one way or the other. So we wanted to start with something that would give us at least a 4-point change, which is why we went with 8. The reality is that the mean score on this population, the treated patients, was 15.2, so that the majority of these patients did have severe PTS. And I think in reality, you know, ethically, it would be hard to justify treating somebody with a score of 8. But the vast majority were moderate to severe, with, again, the mean score of 15.2. We did not separate out because the majority were severe or on the upper end of moderate. So there was no attempt to try to separate those classifications.
Thank you so much, Mark. And now it's my deep honor and pleasure to fly all the way to Europe, in particular in Greece, with Professor Vasdekis Spiros from the University of Athens. It's a huge pleasure for me to introduce him also because we shared a precious friendship with somebody that we all keep in our heart, Eddie Karoudiki, that I'm sure is watching at us and enjoying this scientific moment as well. So Professor Spiros, the mic is to you.
Thank you very much, Sergio. It's a very important meeting. Congratulations for this fantastic job you're all doing. Professor Garcia, I will try to make it in hemodynamics. We all know that the problem is venous hypertension. So you treat hypertension by eliminating the obstruction. We have no obstruction all the way down. But what about reflux? I mean, you improve your symptoms, opening the canal all the way to the toes. But what happens to the reflux in these patients? Do you have any data?
Thank you for your question. It's a fantastic question because in the very beginning of the trial, when I first started presenting this, before we started, I was shot down very often by people saying what I'm doing is worsening reflux and I'm going to worsen the situation. But in reality, we saw the opposite. We understand that the veins are damaged and there's not going to be anything that can be done with this technique at all. However, what we were able to see was that, and I wish we had a way of measuring this, but what we clearly saw, and my explanation is, an occluded lead pipe is worse than an open lead pipe. And so you can at least establish flow. And if you have a good calf pump function going on, that blood is now moving out with little resistance. And because we're doing that, these patients are getting significant improvement in their quality of life, which is really what it all is about, right? Everything's about activity and quality of life, no matter what the data shows. So we were able to establish that. I think going forward, it would be wonderful to find out whether or not reflux really matters in this population. It may be that they were suffering so badly that reflux doesn't hinder their activity or quality of life at all. And that's what we've seen thus far. Now we just leave it to our surgical colleagues to figure out how to develop valves to prevent reflux in the future.
Thank you very much.
Thank you so much, Mark. And now it's the time for the audience, that is a VIP audience in this case, because the first question is coming directly from Professor Kabnik, our previous honorary chair, and he's asking you if you see a change in guidelines with approach to Fem-pop DVT now that we have new devices that do not require lytic therapy, Mark.
I hope, first of all, I hope we can establish guidelines, because right now I think people are still shying away from treating femoral popliteal disease based on the ATTRACT study. But, you know, I hope that we do develop guidelines. And again, this was just an initial attempt at trying to show that people can get better by intervening. That was really the key. I don't know that Access PTS is going to be the end-all study as we develop new techniques and new devices that may make it safer and quicker to establish. So I look forward to the opportunity to help you know, create better and easier techniques.
Thank you, Mark. The second question is coming directly from Beethoven. You know that we are always coupling big artistic figures with the keynote speakers, and Peter Golovinsky was our first keynote speaker, our Beethoven, and Beethoven is asking you, he's giving you congrats, and he's saying half of your patients underwent iliac stenting in your trial. Do you think that was the cause of improvement?
Yeah, that's a great question. One of our reviewers actually made us go back and really subcategorize all stented patients versus non-stented. So remember, everybody had to have femoral disease. So when we went back and looked, about 40%, 42% had iliac disease in combination with inflow problems. When we actually did a sub-analysis of all patients that were stented versus non-stented, the graphs absolutely paralleled each other. The degree of improvement was identical, whether they were stented for iliac disease or if they just had infrainguinal disease and were not stented. So the clear message there was that although patients improved with stenting clearly, that the improvement was seen in both categories with or without stents.
And the last question is coming from Andrea Brennan. When there is PTS, DVT, how long until decongestive lymphatic therapy can begin without worrying about dislodging the clot?
So because at the end of the procedure, there is no acute clot, everything has been cleared out, we start on therapy immediately with compression. We use actually pneumatic compression boots during the lytic procedure and continue until they're discharged later that second day. We tell them to wear their socks every day afterwards, as I said, and get them to start doing anything that they can to improve that calf function. And if they want to get manual massage, we tell them to go at it. They're now therapeutically anticoagulated upon discharge. So anything they want to do is fine. We've not had any problems with having any development of pulmonary embolism.
And then we have the last question from Cleopatra of Phlebology, as we said, Vasilata. Congratulations for such good results. Dr. Mark Garcia, did you have subgroup analysis for provoked versus unprovoked PTS? And what is the medication you put your patients on after the procedure? So
no, we do not have provoked versus unprovoked. It was just a matter of chronic veno-occlusive disease in all patients. And as far as the medication goes, as I explained, the primary medication is enoxaparin at 1 milligram per kilogram twice daily. We explained to the patients why we want that, why they need to do the injections. And we start it usually the day before the procedure and continue with it for 30 days afterwards before we transition them usually to one of the novel oral anticoagulants.
Thank you so much, Mark. I take this chance to deeply thank once again also Professor Aumann for the wonderful performances. And now it's time to wrap up the concepts. And we will do this thanks to 3 stellar faculty members, Professor Gasparis, Professor Narayan, and Professor Wang. We always go in alphabetical order. So the mic is first of all to Professor Antonius Gasparis from Stony Brook University, North America, of course.
Thank you, Sergio. And I'd like to congratulate Food for Veins, Veins for Food. And I also want to thank Sergio, Willie, and Oscar for a great event. Finally, I want to thank Dr. Halai and Dr. Garcia for some excellent presentations on chronic venous obstruction. Now, we all know in medicine that when a patient suffers from any type of disease, the management of that patient and the outcomes is dependent on the severity of the disease. And that's no different whether we're talking about cancer, aortic aneurysms, and as Dr. Jalai mentioned, in chronic venous obstruction. He talked about a classification system that basically allows us to differentiate the severity of disease in patients with CVO. And we know that based on that presentation, how we manage these patients and what their outcomes of intervention varies significantly depending on the severity of disease. Whether the disease extends down, whether it's thrombotic, non-thrombotic, whether it extends down below the inguinal ligament, whether there's involvement of the femoral or deep femoral vein. And all these things, I think, are critical in order to decide how you're going to talk to patients, what to expect after intervention, and what their outcomes is going to be. And whether to intervene or not. Now, let's not forget that classification, although important, there's other things that we need to take into account. And those include things like whether the patient is hypercoagulable or not, what type of stent design is being used. We have all these stents coming out. We don't know how they all behave, if they behave differently. patients maybe even BMI, how good their inflow is. We talked about how we can measure inflow and whether you have an open femoral vein or not. And finally, what anticoagulation protocol? I think everybody in this panel and anybody that's treating patients has probably a different anticoagulation protocol. So although classification system is very important, I think we also need to realize there's multiple other things that we still have many unanswered questions. Dr. Garcia then went on to talk to us about chronic DVT and diagnostic and therapeutic decision-making. And here we are talking about how do we evaluate patients prior to intervention, and how do we decide when and how to intervene. When it comes to diagnostic evaluation of patients, there's multiple things that we need to take into account. Very interesting in his talk, which I haven't really thought about, but probably something to think about even more carefully, is the timing of intervention to the timing compared to when a disease process started. So will outcomes change if we intervene at 6 months versus 10, 15 years later? And will patency change? Obviously, patients how they present, whether it's pain, swelling, ulceration is also critical in your decision-making. And finally, he talked to us about inflow, and that the fact that femoral vein disease should not prevent us from intervening in these patients. So access in these patients during intervention is important in order to improve inflow all the way. And Dr. Haley talked about the difference in the outcomes of intervention with iliac disease, varying anything from 60% to 90%. And Mark showed us that if you improve inflow, you can improve your outcomes even in patients with more severe disease. So it's critical to be able to identify the severity of disease, the extent of disease, and improve inflow in order to improve overall outcomes. I'd like to thank again Dr. July and Dr. Garcia for their presentations, and Sergio and the rest of the group for allowing me the opportunity to kind of summarize the results.
Thank you so much, Tony, for showing once again your wonderful expertise on the topic. Now we'll enjoy the same service from my actually squash teacher and a wonderful professional, Professor Sriram Narayan. Ram? You unmute yourself. You have to mute yourself, Ram.
Thanks, Sergio. Thanks, Willie. And thanks, Oscar, for again organizing this wonderful, wonderful program. And Mark and Dr. Haley, thank you so much for 2 wonderful presentations. I'm not going to summarize all the results now because Tony, as usual, has done a beautiful summary for everyone to go over, but I will go over some thoughts to add to what was said. Firstly, it is excellent that we now have an anatomical classification where we can compare stents and procedures, because the differentials seem to be too much between different interventionalists. Just a couple of questions for us to consider on whether a grade 1, which is it really a chronic venous obstruction? It is a functional obstruction, but should it be in a post-thrombotic system or should it not? That is something to consider as we begin to adopt this. Like you have a sort of C0 in the CAP, should we also have a sort of 0 in Dr. Halai's classification? Something also to consider in my view is whether such a system needs to exist anatomically for the extent of acute DVTs. Tony brought up the issue of timing on whether results will be different between 6 months and 15 years. I would suggest to you that the difference will be different if you intervene in the clot, between the extent of the clot, and whether you intervene in 1 week and 3 weeks and 6 weeks in actually doing clot removal. So perhaps such a system needs to exist to guide us through acute DVT interventions and lysis or no lysis as well. The results of the Access PTS study, Mark, are superb, and they are so encouraging. I'm one of those who does tend to intervene in the Fem-popliteal segment. I'm so pleased that you introduced the dual puncture technique to this audience. It's something we use for acute DVTs, where we have a popliteal and a posterior tibial puncture and do half dose lysis from both ends. You tend to get better results because often the popliteal segment's involved. that it could be used in a chronic DVT scenario. This is new to me, and I'm thankful that you've not just introduced it to all of us, but also shown us how good the results can be. And for those who might find a posterior tibial vein puncture difficult, my suggestion is you can actually puncture the dorsal venous arch of the saphenous and enter through the first perforator. You will enter into the posterior tibial. For someone not quite as skilled as Mark, someone who's far less skilled like I am, I prefer to use that technique because I find it easier to enter. There's something I also wanted to mention, that probably we missed the role of an AV fistula. That has not been the subject of a discussion. Mark's results are superb with the pure endovascular technique, but I tend to use AV fistulas a bit more liberally in patients who've had long-standing occlusions because the inflow system tends to be that much more enhanced, but perhaps that needs to be looked at. I'm also glad you mentioned the visible wall improvement on duplex in terms of compressibility or pliability of the wall, even though the valve function may not have returned, and that there's an apparent duplex demonstrated reflux, which may not be significant. I'm glad you mentioned it because just last month in June in Phlebology, we published the physics of venous return by repurposing a Guytonian equation. It's taken me all of 5 years, but it is Guyton's equation from 1952, where essentially the venous return is proportional, firstly to deep venous pressure and inversely proportional to the resistance of the vein wall. So I suspect with time, the venous resistance of the vein wall comes down, it becomes more compliant, and so venous return improves. And the deep venous pressure has already fallen because of the recanalization that you have successfully created. So it fits perfectly into the Guytonian equation we published last month. And I'm so happy that there is some sort of validation of what was essentially a theoretical concept from somewhere completely different in terms of practical achievement. I would like to finish again by saying thank you all very much for 2 great presentations. And thank you, Sergio. Thank you, Willie. Thank you, Oscar, for this wonderful program.
And thank you again, and particularly thank to you, Ram, and all the wonderful colleagues also as Professor Gasparis and all the other ones who have provided splendid lectures as additional educational material. So I invite all of you to enjoy this material as well. It's my true honor and pleasure now to move to Professor Jinsong Wang from Sun Yat-sen University, China. And I'd like to take this chance to deeply thank also Professor Chi for the wonderful work done with the Chinese friends and colleagues to have also simultaneous translation today.
Thank you, Sergio. Yeah, thank you. And thank Vivian Foundation to organize this excellent webinar meeting. So to bring international experts on venous disease together to discuss one of the most challenging disease, PTS, during this wonderful time. And I would like especially thank Vivian to have the simulation Chinese translation, and so more Chinese vascular surgeons can enjoy our webinar meetings. And today I learned a lot from these 2 excellent speakers, and thank Dr. Holman gave the guideline of the classification of guide the management of PTS. Well, Dr. Mark Gessier reversed this conception a little bit, and he talked about lots of cases on femoral infrainguinal disease, which is excellent. So in China, we are for PTS, we mainly treat the patients with iliac occlusion, and the compression is the dominant therapy for the PTS. And so from this meetings, so we would like to, maybe we can try more on the PTS with femoral popliteal vein occlusion, and we need to do more further studies on the prevalence and the scores and the outcomes of the PTS with Fem-Popliteal occlusion to development into PTS. And another points like we learned is the manage and how we use the image studies to define the loci of the disease, and then can guide us more precisely how to do the management. Either use IVs or CTV or MRV or duplex. I mean, like this could be a more a study topic for us to study further. And so I want to add like the stent, like what stents we should use for iliac vein occlusion. Like shall we use bare stent or could we use the covered stent? And we should study more on this point. And we are learned from the two speakers of the anticoagulation after therapy, and what kind of anticoagulation. Dr. Mark Gassier said low molecular inoxaparin for 1 month and then to the oral. And in China, we currently use a lot of Novix right now for this patient after treatment. But maybe we do not know Novix is good or not, but we can to design our study to focus on how to use the anticoagulation among these patients. And so I would like to comment later we might invite the Dr. Mark Gassier to talk about more on the technique, how to cause the CTA in a Fem-Popliteal vein, because I think that is a very challenging technique to improve the technique. And also we could Cyril said we can talk more on AV fistula for the endotheliectomy for the patient. And finally, I would like to thank Vivian Foundation and Sergio, Willie, and Oscar to give us this wonderful opportunity for our international society to focus on this PTS. Thank you.
Thank you so much, Jin-Song. It's our true honor and pleasure. It is me thanking deeply Oscar and Willie. Without them, nothing would have been possible. So I will leave the mic now to Oscar for some final remarks.
Thank you, Sergio. You know, education is in my heart. And today we understood we all must be educated in deep venous. Even if we don't practice on deep venous system, indeed, we have an important chance to meet patients with deep venous disorders, and we must offer them a significant contribution by eventually addressing them to the right specialist. Still being able to judge to the eventually offered diagnostic and therapeutic option offered to them by a colleague. Thank you all again, and see you next weekend.
Thank you so much, Oscar. Willie?
Thank you. We're getting close to the end, so I only have a few words. Great lecture from Holman and Mark, as always. I believe that in short of everything we do for our patient is central to our care. So I think that all the panelists and including all the chairs have focused on the fact that ultimately it's not us feeling better, but we need to make the patients feel better. And with that, I want to thank again my partners Sergio and Oscar for giving the opportunity to have the simultaneous Chinese translation to our Chinese colleagues.
Thank you so much, Willie. And now we go to the conclusion. Next week, we wait for you for the module dedicated to compression. We will have the pleasure of having Professor Chi talking together with Professor Cavezzi and many other top renowned experts from all around the world. Once again, I'd like to deeply thank all the ones involved in this group effort. I deeply thank once again Vasco da Gama and Cristoforo Colombo of the Deep Venous System, and particularly for their availability during the week that is coming in answering to all the questions that have been made today. So you will receive all the answers published in the website. We are at a turning point in this moment talking about sailors, because it's exactly the half of Food for Veins. It's like 6 modules of 12, and it's a turning point. And sometimes when you are navigating, you have to be able to steer the boat in a different direction. And since in life, it's not where you go, but also it's about who you're traveling with. On August 2nd, we were supposed to have the lymphatic module, but we will be more than happy and honored to postpone August 2nd module to August 30, because on August 2nd, there will be a not to be missed meeting, a meeting that everybody should attend at least once in a professional lifetime. Same for CISE, same for International Inter-University in Buenos Aires, same for Pan American meeting and many others. So we look forward for being all together virtually in New York on August 2nd, and then we will move forward. But next week, we'll be again together for the module dedicated to compression. I once again deeply thank all the stellar faculty involved and all the ones who have joined us today. I see we are already more than 1,000 and far more, so we will have the report later on. And with this, I look forward for having you with us next Sunday. It's 5:30 p.m. Italian time, and I so wish we could have an aperitif together, but it will be next time somewhere in the world. Thank you so much all. Bye.
Bye.
Well, thank you.
Have a nice day.
Bye-bye.
Bye-bye.
Have a good day, everybody. Bye-bye.
Bye.
Thank you.